I would like to introduce the next speaker, Mrs. Kerstin Peuschel is going to speak. Mrs. Peuschel has been working with bioresonance according to Paul Schmidt since 2006. So she has been working with it for a long, long time. She has a heavy load of experience. She started with a biometer, I think, but what is excellent for her that she has managed to make a bridge from the classical medical science to our science. That if she uses an ambulance in these times of COVID, things look different. Sometimes she can still laugh about the present situation, but at this stage, I'd like to say I'm very grateful to the fact that she has also participated at several pain seminars we have had online, and she was still able to save people, to rescue people with classical medical means. So she has been combining things, and now she's going to talk about chronic pain. I'm looking forward to it, and I'd like to welcome Kerstin.
Noch einmal, Sie haben ja, vielen Dank für die Anmoderation.
Thank you very much for the introduction. You have already heard something about me, so very briefly, where can you find us? Almost in the center of Germany, close to the A38 motorway. Heiligenstadt is a small spa town, and in this building is where our clinical practice is. You can have a look into the practice. We have 6 treatment rooms and 5 devices by BSC Polar, and small home devices, PSC PS10 Med, which we give the patients for outpatient therapy at home. I have the honor of holding the first presentation of this online World Congress. I'm very glad about it. I'm also very glad about the possibility of reaching out to so many people in the world. It's slightly different from usually. We miss the personal contact, but I still hope that we can make up for it in this Congress and that we have a nice time together and we can convey many things. I simply would like to start with my presentation, create a shelf system by which you can order your knowledge you already know and the newly acquired knowledge, so we have a common basis. It's about knowing what is pain, what is chronic pain, where does it come from, and how can we treat it, how can we treat it best, because I think that when you have a basic understanding of these things happening, it's better to treat the patient, and that's what you all want. First, which was very interesting, as a therapist, we are obliged to take on pain and alleviate it. Often it doesn't work because the disease is mostly chronic. We have a time problem. We have an issue which also affects our therapies because they are time costly for patients and partly also uncomfortable. But we need to give acute help. We need to combine different processes. First, it's bioresonance, according to Paul Schmidt, but the patient also needs some injection, infusion, or any other method for treating pain. What is important is that we go along with the patient. We need to inform them, or educate them. What do we do with them? How is the sequence, the time sequence? What measures are being implemented? What risks are there? Also, this the patient needs to know. Are there undesired effects, side effects I need to count upon? And do I have treatment alternatives? Anything that doesn't work, and how can I communicate with my therapy at that time of the day? This is very important to accompany the patient along this way. We need to give them a therapy and inform them, and the better our results will be. Well, pain is something that makes sense. It's a first symptom of a disease and also has a warning function. This is very important that we say, okay, something is not fine with our body. Of course, we also have the possibility of taking pain suppression. For instance, if we are in an acute flight or stress situation and we cannot take care of this pain, we have opiates and cannabinoids by the body that are secreted. We have the proliferation of PR receptors, of neurons in the bone marrow, but also segmental pain inhibition. We can do all this because pain as such is there, and it also affects our vegetative nerve system. The sympathetic tonus increases, secreting adrenaline. This is different with everybody. Every person is different. The basic features of pain processing is different, but in the bodily constitution is set down how I am equipped with pain receptors, how does my pain suppressing system work, and how do I manage this pain? Can I take it out? Can I somehow influence it? Do I have any possibility for my psyche to react adequately on it? And how does my personal environment, my social environment to this disease I possibly have? Also, the disease itself plays a role. It's a chronic thing when I say, okay, I have little possibilities for therapy, or I know that I just wrist my ankle. So this is something which the receptors affect in the pain vibration. Here, I placed how this pain is created with something that have some effect on the cell, anoxic and mechanical, for instance, a sting, a caustic and thermical, heat, cold, chemical, electrical stimuli, or infectious or pathogens that create tissular damage. And here the pain transmission, pain elaboration processing is the same way. The body doesn't care what the NOx is. After the tissue and cell damage, mediators are released, and these nociceptors are stimulated, and the pain is transmitted to the central nervous system and is processed in the brain. It's also very important, this processing is individual. It's different with each patient. How does it work now with chronic pain? Here we have the situation that this senseful physiological signaling and protection function has gone lost. It's not there anymore. The pain has become autonomous as a pain syndrome. It has been there for months or even years. So such chronic pain patient has the pain, but also the reaction of vegetative nervous system, all this steady pressure, the sympathetic tonus. People have insomnia, depression, less of activity, even also eating disturbances. This can be measured with the patient because it's sometimes important at the beginning of the therapy to go along with it, but show also the patient what is happening within their body. And such parameters like adrenaline, serotonin, gamma, cortisol, daily profiles, complicated. We can show the patient. Also here in the lab, we see what is the matter with you. Of course, this is shown late in the study, several pain scales that can be created. The patient to the analogous scale where the patient can check from 1 to 10 where my pain level is, what the intensity is, the periodicity of pain. Also SFZ 36, where they describe how my function ability is in the physical, psychosocial area, or also the cervical spine, the neck disability index, where you can see in different sections how I can get through it through life with my bodily activity, with my leisure activities. This has to be checked at the beginning of the treatment, but also in the course of it, so the patient can be followed up to say, okay, what has changed with you? That's very important. How comes up such chronic pain? This can come up at any chronic disease, but also in after acute trauma. Some chronic pain can be left sometimes for wrong regulation of the vegetative nervous system. The patient, this position is the relieving posture is created. It leads to structural change of the nervous cells and also in the pain memory. This is something known in technique with when you have a wrong position, the brain takes this as the new set point. You can try it out. If I want to test it, I will relieve my left arm. After a short time, you'll notice that you do it also subconsciously, and that's very difficult to recover a normal movement rhythm. We have this also with patients with chronic back pain, because the stretcher is very tensed as the abdominal muscles are not charged anymore. The patients have the feeling of falling forward after 1-2 days because this nominal value has been changed in the brain. They cannot take a right position in space. So this is a very big problem, and when you imagine that these are chronic pain patients that have been having that for many years, you can see that this is an issue, this pain memory, and to break through it, you need many methods. And what I've shown in the previous slide, you need to create a control with this pain scales, but also with the lab, so the patient sees clearly what is happening, so you can make a psychological follow-up. Then the pain syndrome has multifactorial parameters. That's clear. I said before that the attitude of the patient, how does everybody deal with the pain? Do they come over it or do you enter it? How is it with their family, their friends? When they come with pains, is it played down? How do they deal with it? Are they socially isolated, or their friends tell them, stay at home because you don't do anything anyway? How is the working satisfaction? Because precisely in the cervical spine, we have problems at the job. Also, the job triggers this situation. Is the patient satisfied with their job? That's also important for treatment, or treatment for adequate treatment. What is the expectancy of the patient with us? Most patients come after having gone through a whole ordeal and at many therapies, and they have been admitted often to hospital, and you need to take the patient where they are and be honest to them and tell them, what can I do for you? What is realistic, and also within what time, and especially also, how can I do this? I need to tell them, okay, the therapy will probably take that long. It's probably that we will expect some improvement. What do I sort of therapeutical measures do I take? It's important that our therapeutic patient relationship is improving? Are we still at the same level? Do we work together? Or has there created some difference? So even perhaps codependencies between both sides, that's not very useful for treatment. And what responsibility? Is the patient ready to bear it, or do they just relinquish it completely to a therapist? That's not wishful. Are they able to work in compliance and go along all these things we're going to do with them? Here I wrote again what areas have an influence on the chronic pain, and it's clear here that these areas have to do with each other. Of course, we have the physical, the motorical level, tensions and relieving positions, the neurovegetative level with insomnia, tiredness, being always under tension, because they go from one therapist to the next. They want relief in their pain. They're fixed on their pain. If I have only want somebody talking only about their pain and cannot participate in anything, they will be isolated from the environment. Patients sometimes take uncontrolled drugs, which often reduces the activities. So there comes a point where patients are completely frustrated and cannot deal with stress, nor with any setbacks in therapy. So then we have the loss of competencies. Many patients don't do anything by themselves. They completely relinquish their competences to a therapist. And here you need to be able to see, okay, here I can do something about it, or I have to do something about it, because the patient needs to re-enter their own self-responsibility. This is an important slide for therapy. We can classify this chronic pain in a different way, and only with this classification I think we are able to talk about how to deal with the pain and its causes. We have this pain with an intact nociceptive system. I have disorder at a certain point, inflammation at an extremity where pain happens. There may pain perception, the transmission, and processment at the brain. We have the chronic neuropathic pain. It's not only the local area, but part of the pain transmitting system is also affected. And then we have the central pain syndrome, where we have peripherally no lesions, but the disorder is directly in the brain, in the processing centers, which usually occurs after stroke, bleeding. For instance, these three groups need to be tackled differently. You sometimes see it when the patients and the drugs, there is these peripherally useful analgesics, generally no, and derivatives of arachidonic acid. We have it goes into the prostaglandin system. They all relieve pain. They all reduce fever. They are antipyretic, and they are also anti-inflammatory, and they have also allergenic potencies. So depending on the chemical composition, they have a different effect on these three groups: anti-inflammatory, antipyretic, analgesic. We all know, for instance, the ASS or its derivatives, clofenac or ibuprofen. We know COX-2 inhibitors, paracetamol, metimazole. All this acts on this pain with the intact nociceptive system. All other pain types often require the second group of pain remedies, opiates, which are derivatives of morphine, either synthetical or semi-synthetical, or also as natural morphine in different application forms. These analgesics can be combined. You can read it also in the pain therapy scale often from group 2 on, the cooperation of peripheral analgesic with opiate like postnostalgic. These peripherally active opiates are combined with light opiates like tramadol, or also with outright opiates of stronger effect. And if we go further into the central pain syndrome, it makes no sense anymore of including the peripherally effective analgesic. You need to therapize opiates, sometimes with tricyclical antidepressive that act on this vegetative nervous system, or even with neuroleptics that process pain in the brain. And all this is also important when I want to work with bioresonance. I can think thoroughly what sort of damage is there. Where is my problem? Is that in the periphery, or do I have a chronic neuropathic pain or a central pain syndrome? And also there, we can orient our therapy. Must I include the therapy, the nervous system, or bioresonance, or even some regions in the brain, opiate receptors, or so on? All this I can do, and here in my bioresonance therapy, if I'm clear about this scheme, I can be more specific and to work more specifically with the patient. What does that include? It's pain history. It's not only that I say, where's the pain, for how long did you have it? It also includes that you make a very specific history, that you take your time to explain what they are experiencing now. This also includes their own history. What did they have so far? Surgeries, some scars, some tooth implants, allergies, anything else. This is important as well as what is their nutrition habits, how do secretions, everything okay? Is there problems? Do they have things they like to do in their food? How much do they drink? What has so far occurred in their family? What is the family history? Is there any reference to possible inherited diseases? And it's possible to say, okay, how does it work socially? Are you including the job? Are you satisfied there? What is your job exactly? You can have them show that when you say, okay, I'm working at the machine, you can have them show you what is that? What sort of activity do you do there? What movement is there? Are you sitting? Are you standing? All this is important. And also, how is working in the family? Do I have friends? I include in the family? I have a good position. And only then you go directly to pain, and you can say that's very important to write it down. The localization, does it irradiate somewhere? Are there areas on the skin that somehow also do react? For instance, also with some eczema, what is the quality of pain? Is it sting? Is it burn? Is it pressing? Is it changing quality? What's the intensity of the scale I mentioned before from 1 to 10? Are there any periodic things, seasonal influences in women through menstruation, certain things like stress, beginning of a week, and recovery times? Or is there anything that is affecting pain? Heat, cold, or anything the patient does which reduces pain, laying down, sleeping, diversion, anything. How does it work? Are there any accompanying phenomena, sweating, fatigue, palpitations? This is important for our therapy. And also, what does pain do with you in your life? What limitations do you have? And what are you experiencing psychologically? with these diseases. Of course, it also includes what measures are combined with what success with patients. I would like to come to the cervical spine syndrome. This is relatively unspecific collective concept for many symptoms in the cervical spine, the back, neck, shoulder, arm region. This area is bearing a high charge. We have the lesion of cervical marrow is not compatible with life or has a severe effect on the patient's health. We have the affluent vessels to the brain. The movement needs to go into several directions. These are two things that don't match really. The head, of course, has a very unfavorable center of gravity up there, and due to our lifestyle, we are under threat of having lesions there. When it was placed there, so to say, when we were primitive humans and living in caves, we didn't have that. The trauma cinematics we have with accidents, with sports, even in our everyday life, working at the computer and the leisure activities that with many are based on sitting on the couch before the TV. This didn't exist at that time, and for this reason we can see that these muscles that are not very strong in the cervical spine, the supporting structure, have to allow for big flexibility, but also need to protect and hold. This is overstressed. I noted down the nervous segments of the cervical spine, C1 to C7, what supply strands we have, the anatomic structure. We see the we have the neck muscles, diaphragm. It's a big part of the body, this upper part of the body that may create problems that may lead to pain or distress or lesions of the cervical spine. I have divided into different areas. Pain in the arm, in the thoracic musculature, also the time and causes, but I think the best classification is between specific and non-specific. Non-specific, for instance, overstress of muscles and fascias and their shortening. For instance, we have many seated activities, PC working. There are hardly any counter movements. People don't have time to have sports, do sports after the job. There are also the possibilities limited. Many go to the fitness center and the gym. It's also charged the sleeping position sometimes, and also our stress we have. Many patients have fears, and this makes us shrug the shoulders and the head. Our scalenus muscles are under tension. It's difficult to stretch them. So here we have a shrugging of the musculature, and they have to counter tense the back because we need to keep our head straight. And for that reason, we have chronic tension. Many look often on the down to the mobile phone. This is an additional stress for the neck muscles. Of course, there are also specific causes like arthrosis in the small articulations of the spine, osteochondrosis, also inflammations of the disc, also of the rheumatic form part, and also the lesions within the neck due to small traumas we have in sports, traffic, and others.
auch in
the unspecific causes can be, of course, it can be combined with specific causes, because the tension you have in the back also leads to changes in bones or articulations. This is something you see with young people as well, because we know that the head already weighs about 5 to 6 kilos. And if I have a posture of looking downwards for the whole time, looking at your cellular phone, it would be like having a small child hanging on your neck, and this causes changes in the bone structure and the articulations. And we can see an increasing number of young people who have these changes in their bones, and they can't manage to be able to be standing straight against a wall. On the other hand, I have maybe a wrong posture in the spine, or maybe I have had a trauma because of an accident. Then the spine and also the muscles will have unspecified changes sooner or later, so you can't really distinguish between what is specific and what is unspecific. Well, what can I do if I have a patient with a syndrome in neck, spine, and shoulders? We have to have an anamnesis, so we have to have the whole history of the patient previously from his visit. So I have to have a look at all the various diagnostics, and I have to have a comprehensive overview. And once I have this, I can carry out physical and neurological investigation. Diagnostic measures, we have MRT, we have X-rays, we have the computer CT. Well, this is indispensable in order to make sure that I don't oversee anything, because many neurological diseases have already been overseen by many doctors in the past. So I have to exclude all these possibilities before I start treating the patient. Which kind of treatment possibilities do I have? I have mentioned the medical pain therapy with medication. And I have to think about, well, does it fit? Can I combine it with what I'm doing? Then the physiotherapy, we have all sorts of different kinds of massages of tissues, and so many different kinds of massage types, and using heat or cold, pelloids, or electrical treatments. So relaxation therapy is very important, because patients all suffer from an extreme high activities of the sympathicum system. So they are tense, and we already mentioned this before, and this promotes or accelerates the vicious circle of maintaining pain and repeating pain, and the problem which will be caused in the social sphere. Psychotherapy may be necessary, or at least the first discussion with the patient, in order to find out how can we proceed in therapy with psychotherapy simultaneously. Homeopathical treatment can also be accompanying the treatment. So here we have a good combination with psychotherapy. And then, of course, naturally, the bioresonance, according to Paul Schmidt, is something which we would use. Then it is one of the main parts of the treatment, and it's one of the supporting pillars of the treatment. It's always there. And why is it part of the treatment? Because the bioresonance, according to Paul Schmidt, in difference to all the other named treatments, will cover all these different areas. We have a complete, comprehensive, holistic approach. So the patient will come to the doctors, and so he is going to have a social integration. He's going to be taken out of isolation. He's going to be accepted with his or her disease. He can talk about it, or he or she can talk about it. That's very important in order to make sure that the diversity of the different diseases can be recognized, and he or she will be taken out of isolation. So we have different causes which will be bundles, and we can find out about them. Is it just a leisure? Is it something, what is below the leisure? Is there attention? So the patient will be integrated in an agreeable, nice atmosphere. Bioresonance is an agreeable therapy. It won't cause any discomfort or the theory at home, on a bed, on a couch. This is something which is usually accepted extremely well. So we have the possibility to treat the patient at different levels, the physical, but also the psychological, what kind of parts of the body should be integrated, and the social aspects as well. Furthermore, I can have a look at the neurovegetative level. It can also be included. And here we have the distribution in different pain sections. I can also increase vitality. I can also reduce the stress load, or if contractions, if patients have contractions, I can reduce them. So I can have a tailor-made specific approach for this one patient. So we are working at all different levels simultaneously in order to get at the causes of pain, at the pain load, and we also have the possibility to adapt things in the course of the treatment. What has changed? Is there anything new? And I think it certainly makes sense to talk about it with the patient, so that I can always adapt the therapy in the course of the duration. Well, this is the end of my presentation about chronic pain. I hope I could take you with me on this journey through chronic pain. Of course, there are many more questions and issues. If you have any questions about my presentation, please ask me about it, or please get in touch with me. We will try hard to answer your questions as soon as possible. I hope that you're going to have a great fun during the Congress, and that you can use the many new things which we are trying to make available in your practical therapies. Thank you very much. Thank you very much. And as you said yourself, we have the possibility now to let people ask questions. I would like to ask the technicians now to have our first questions asked. So please, I hope that works out. So these are the questions we have received via the chat. Now, this is the first question where it works out really well. I'm just reading the question so we can all hear it. Pain reduction with bioresonance, according to Paul Schmidt, is only meant to be used for chronic diseases. No, certainly not. It's not only for chronic pain, but it's also for any type of pain. But I have to classify the pain. Is it a peripheral pain? Is it a deeper pain? Is it a pain which is temporary? Is it a chronic pain? Is it a centrally caused pain? So it's very important to categorize the pain. And then when I have done it, I can produce a tailor-made therapy. So, but any type of pain can be treated. The second question: what are the most usual diseases at which you use the bioresonance, according to Paul Schmidt at the Paul Schmidt clinics? Well, I say this jokingly at the end of an event. Some patients come after a long odyssey with chronic diseases of a different kind, and they have seen many doctors. They have a skin, ligament diseases, neurodermis, all sorts of different diseases, or musculoskeletal diseases. H syndrome, which is neck, shoulder, and spine, and diseases of the neurological system. And we also have psychological diseases, psychosomatic diseases, neurovegetative systems, allergies. So there can be a whole array and broad palette of different diseases, which could not be treated successfully with classical therapy. And everything what is chronic and what cannot be treated by the classical or traditional medical physicians will turn up at our clinic. All right, then. Let's come to the third question. We have a third question here. And it's a question from France. Bonjour. And I'm going to read. If I were a patient from France and I would come to your clinic, can I be treated stationary and then continue therapy at home? And can people with disability get into the facilities in Germany? Of course, we have treated several patients from far away, stationary. Of course, now we have restrictions because of the coronavirus. So we would now start with an ambulant treatment because of COVID. But once times change, we will be able to treat patients stationary. Because in the past, that's what we did. Or at least we would accommodate them in a nearby hotel, whatever the patients prefer. This is something we would discuss with the patients. And then we transition the patient to a home therapy. So he or she will be able to get home and he gets a precise treatment plan. And the PSK, our clinic, is free for disabled people. So, well, I'm very glad that we couldn't answer, we didn't have to answer this in French, so because that would have been extremely difficult.